Dear Chairman, thanks for the invitation to the ABC 221 Congress. I'm Dr. D'ASCENZO from Turin, and the title of my presentation is The Adverse Events of Dual Antiplatelet Therapy for Patients Treated with Stents on Unprotected Left Main or Coronary Bifurcations. And recent evidence have shown that the risk of MI in patients treated with different kind of length of DAPT does not differ. For example, in this recent network meta-analysis published on JACT, de-escalation did not increase risk of subsequent MI or revascularization of death, and of course, reduce risk of minor bleeding. And this is something very important. But from the other point of view, we all know that in this randomized controlled trial, patients with high-risk PCI are not represented or underrepresented. For example, in the ONIS-1 trial, only 12% of these patients were treated with a bifurcation with 2 stents, and of course, these patients were a high risk of recurrent events, and only 5% of these patients were treated with left main PCI. Similarly, in the global leaders, we have something more regarding sample size. About 10% of the patients were treated on coronary bifurcation. Again, we don't know the kind of strategy used, that is, we don't know if these patients were treated with provisional stenting or with stenting with 2 stent PCI, and we don't know even the technique of 2 stent PCI. And of course, these patients have a higher risk of recurrent MI and of any subsequent revascularization, and also stent thrombosis, both definite and probable. One of the few trials reporting some data about complex PCI is this non-pre-specified analysis of the STOP-DAPT trial. The authors tried to put together all the complex PCI, that is about 17%, including 3 vessel PCI, more than 3 lesions treated, a long length of stents, and also bifurcation with 2 stent strategies, which were clearly underrepresented, and putting all of them together, a longer length of DAPT, 12 months of DAPT, reduced risk of MI and thrombosis, that is risk of NACE, compared to 1 month DAPT in complex PCI. And this trend was not present in patients with non-complex PCI. But of course, as you may clearly depicted from the Klappenmeyer analysis curves, these patients were underrepresented, and so we're speaking about a few patients and really a little number of events. In the Grand Death Registry, which enrolled 700 PCI performed on unprotected left main, DAPT interruption before 12 months represented a marker of risk for target lesion failure and from thrombotic event recurrent events in the vessel and on the other vessel. So the take-home message from this registry was that a long DAPT, even longer than 12 months in these patients, may be of interest. The COBIS 2 registry, including 2,082 patients performed in Korea, demonstrated after a propensity matched analysis that DAPT longer than 12 months reduced risk of death of MI, and these results was confirmed also in all subgroup analysis. Interesting, the only limitation of this registry was that most of the stents used were first generation deaths, and so the question which arises was if the results of second generation death, which was neutral about the benefit of longer DAPT, was derived from the low sample size or from the protective effect of second generation of thin or ultra thin stents. So we tried to analyze all this data together. That is, we included the data from the COBIS and from the RAIN registry, and we created the Bifurcat registry. That is, we put together our patients to reach about 5,000 patients treated with PCI on bifurcation or unprotected left main, and we try to analyze the potential benefit of DAPT of 6 from 12 months versus DAPT shorter than 6 months and DAPT longer than 12 months. We performed 2 subgroup analyses, that is, patients with acute coronary syndromes and patients with chronic coronary syndromes. In patients with acute coronary syndrome, the benefit of DAPT between 6 and 12 months was not present when compared with DAPT shorter than 6 months, but also after multivariate analysis, DAPT longer than 12 months reduced risk of major adverse cardiac events compared to DAPT between 6 and 12 months. And these results these benefits disappear in patients treated with PCI because of chronic syndrome, in which the trend was not significant both when comparing DAPT between 6 and 12 months versus DAPT shorter than 6 months, or when comparing DAPT longer than 12 months versus DAPT of 6 and 12 months. And in a multivariate analysis performed with different techniques, the benefit of DAPT longer than 12 months was confirmed from DEF, from MACE, and from subsequent MI in acute coronary syndromes, but was non-confirmed in chronic coronary syndrome. And again, we performed a subgroup analysis in these patients, and the benefit of DAPT longer than 12 months was present irrespectively of strategies performed for bifurcation, that is, choosing strategies, provisional stenting, both for patients treated with left main and non-left main, and also independently from the DAPT score. But the benefit disappeared in chronic coronary syndrome. So the conclusion is that we know that patients with bifurcation are underrepresented in randomized controlled trial. In observational registries, even after adjustment for confounders, a long DAPT seems to exert a protection from HES patients, but it does not exert protection from chronic coronary syndromes. So if the bleeding risk is low or acceptable, a longer DAPT seems to be reasonable for HES patients treated with PCI on bifurcations. Thanks again for the invitation to this meeting.